if you adopt this principle of evaluating someone comprehensively for obesity and really optimizing everything you can from a behavior lifestyle perspective, optimizing that clinical model, and using a whole armamentarium of medications, not just the new GLP-1 drugs, it actually is a great investment. For a lot of our clients, they know that the health of their employee population, the health of their member base over the next 12, 24, 36 months, or some even, like with the state of Connecticut, into retirement, is going to be their liability. And they'd rather invest now for that benefit than suffer the consequences in many different ways down the road.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
The obesity epidemic continues to strain our healthcare system with outdated clinical practices and limited coverage, making effective treatment elusive for many. To confront this pressing issue, innovative solutions and visionary leaders are essential. Enter Sloan Saunders, an entrepreneur whose 15-year career in banking, private equity, and venture capital has uniquely positioned him to drive meaningful change in healthcare. In 2022, Sloan and his company were selected to join the UCSF Rosenman Innovator Programs, an initiative dedicated to supporting early-stage health tech ventures through executive mentorship, investment advice, and valuable networking opportunities. Sloan's journey into healthcare entrepreneurship is anything but conventional. After years in investment banking at Deutsche Bank, he co-founded FlyteHealth, motivated by a desire to address the inefficiency he observed in obesity treatment. Leveraging his financial expertise, Sloan developed advanced technology platform that not only streamline clinical operations, but also personalized patient care, treating obesity as the chronic disease it is. Breaking barriers in obesity treatment, Sloan merges financial strategy with healthcare innovation. This unique perspective has enabled FlyteHealth to forge strategic partnership and implement evidence-based solutions that significantly improve patient outcomes while reducing healthcare costs. His commitment to transforming obesity treatment has made a profound impact, offering more accessible and effective care to those in need. In this episode, Sloan shares his unconventional transition from investment banking to healthcare innovation, the challenges he overcame while building FlyteHealth, and the transformative strategies his company is employing to address obesity as a chronic disease. He also delves into the crucial role of technology in enhancing clinical operations and offers insight into the future of personalized healthcare. Here's our conversation. Welcome, Sloan. Thanks for joining me today.
Thanks very much for having us.
I'm excited to have you. And we met a couple of years ago. It feels like a long time ago, but it doesn't feel that long at the same time.
Time flies.
You were one of our innovators that you've gone through the program, but you have made so many progress. And I like to also start the conversation with the story of your journey. What brought you to where you are today?
Well, I guess my journey started in an unconventional way. I focused historically on business throughout my educational career. Started at Georgetown, did an undergraduate in business, and then went on to do investment banking at Deutsche Bank, went over to the private equity side of the world on the buy side. And how I really encapsulate that experience is focusing on inefficient markets. As I sort of thought through different investment areas to focus on, I really loved trying to solve problems that historically focused on capital structures and financings. But after about 10 to 15 years of doing that investment on my own in various industries, my wife came home after completing her residency and med school at Weill Cornell to tell me about a fellowship that she was doing in a new area of medicine called obesity medicine. This is around 10, 12 years ago. And she told me that she was going to be the first clinical fellow in obesity medicine at Weill Cornell. And I looked at her, I said, this is 10, 15 years ago. Obesity is a big issue. How is Cornell just starting an obesity fellowship program now? And she, expanded about her mentor, Dr. Louis Aroney, who helped to create the American Board of Obesity Medicine, and how it was still a very sort of undertreated condition. And Cornell was really making strides in helping to advance this clinical model. And from there, I was just captivated. And I joke there really hasn't been, as inefficient a market as I've seen in the clinical treatment of obesity medicine. And so from, those initial conversations with her mentor, Dr. Roney, really understanding just the inefficiencies that we observed through those conversations and interviews with leaders at health systems, we really try to think creatively on what could be a meaningful way to change that paradigm.
And from your conversation, you mentioned that you identify a lot of the inefficiency. There's so many inefficiency in healthcare and in this particular space. What did you observe that inspired you to, this is the area that I'm going to spend 24 hours a day, 7 days a week to think and try to solve?
The list is, I guess, too long to even go through from top to bottom. I would say that the main aspects of where we tried to focus on technology was a big one. What they were doing in their clinical practice was analog at best. Paper notes, a lot of just very outdated ways to perform clinical operations. Even just the clinical decision making, they weren't able to leverage a lot of what they were doing or had done with previous patients to think critically about what to do for future cases. The other thing that was rapidly evolving were the tools in their arsenal. Now everybody is aware of the new GLP-1 agonists, Wegovy, Zepbound. But back then, they still had a few medications, but there wasn't as much attention to those various options. And so when we started to build the technology, Dr. Roney really helped to key us into just the roadmap and the advances that were coming down the pike. And so what we built was a technology platform that really helped a clinician phenotype out obesity profiles. And so that's how an obesity specialist views the world, in not a singular lens of obesity, but in the different pathways that obesity impacts, whether it be neurologically, metabolically, hormonally, understanding the different mechanisms of action within certain medications, understanding all the contributors to weight gain, all the barriers to weight loss. And that constellation of data points are too numerous for any one clinician to really factor in, let alone our ability to now factor in possibly genetics, microbiome, larger data sets, and really creating a more personalized approach. But when we started to really unpack all the data sets that needed to be factored in to make a really comprehensive and impactful decision, we recognized the need to create a technology platform that could supplement the clinicians. I would say the other barrier that continues to be pervasive today is just the lack of coverage. And if you look to just the widespread focus on coverage of the medications, I think what a lot of people don't recognize is the clinical services that support that prescribing are not typically covered. And so I think that is one of the areas that we're focusing on with a lot of the payers, is terms of reframing what is prioritized in terms of coverage and really helping to rethink the value of the treatment of obesity as a first-line intervention, and to help accelerate the adoption and the access for it.
When you say the lack the lack of coverage? Is the lack of coverage for them to have access to the medication, or the lack of access for them to get some sort of consult or treatment to help them with their weight?
Yeah. So for most providers or under most payer plans, if a provider were to treat obesity as a first-line diagnosis, it would not be covered and reimbursed. And so obesity as an actual chronic disease is not a qualified diagnosis able to get reimbursed under most health plans. And so the provider is not essentially incentivized to actually provide treatment for weight. They're incentivized and the diagnoses are covered for diabetes, hypertension, hyperlipidemia, all the other basically 200 conditions that obesity is directly or indirectly related for. But if I submitted, one of our clinicians submitted a claim to Aetna, the majority of the time, and I just said I evaluated them for weight, I treated the obesity, and I listed that obesity diagnosis code, they would reject the claim.
Mm. So as a result, they would put it like, this patient has diabetes, but I'm going to prescribe them the Wegovy and the Ozempic.
Exactly.
And why is that important? As far as the patient concerned, they got still the treatment they need.
Well, so I think there's still another fight or battle to be had on whether or not that patient will eventually get coverage for the medication that's being prescribed. So I think a lot of employers, and this is one of the things that we're working on with a lot of our clients, helping to cover the anti-obesity medications. So a lot of employers still do not cover anti-obesity medications, or at least the newer class of anti-obesity medications. But why it's important to also cover the clinical services associated with that is because they're also bucketing the costs for that disease to another disease state. And so that is why when most people look to claims data and to look to other data sets to understand the economic impact of obesity, it's really undercounted or underrepresented because that same clinical visit is now being allocated to diabetes or hypertension when the real root cause of that need for care should be obesity.
Mm-hmm. I know before we go in deeper in the conversation, I also want to maybe give you the chance to tell us a little bit about the work that you're doing at FlyteHealth, because it is an obesity. What are you trying to solve? What the impact that you're trying to make?
Yeah, no, I appreciate that. And FlyteHealth is our rebranding from the old company in telehealth. It's an endeavor to crystallize and simplify our message to the market. When we started, we were focusing just on technology and a software capacity. And when we stood up our clinical services affiliate called Flight Medical, it got a little confusing. And so with this new rebranding effort, we're now FlyteHealth. And what that means is we're a technology-enabled clinical services company licensed in all 50 states, in network with all the major payers, and working with a lot of self-insured entities. The largest of which is what we've been doing with the state of Connecticut, helping to pioneer a new model and cost-effective clinical care for obesity.
You mentioned earlier that you got into healthcare in a very different path. You spent a lot of time in private equity, in iBanking, in the real estate world, which is very different from healthcare. Everybody agree, I'm sure, that you felt the same way too. What are the things that actually, the fact that you are outside of healthcare, that actually make you a better leaders in the healthcare field?
That's a great question because it's something that I've been thinking a lot about as we think about strategic partnerships and, areas of growth for us. I think some of that ignorance actually played an advantage for me. I didn't realize I didn't realize the extent of how some of these reimbursement models are not affected. I didn't realize how inefficient some of these delivery channels have become. And so I think not knowing those friction points and that complexity led me to not be deterred when we started. I think we've definitely learned a lot, and I think we've helped to create awareness in new areas for established players. If you look to even when we started, probably in 2017, 2018, we would spend probably the first 60 minutes, 45 minutes of a 60-minute conversation, explaining to an executive at a health system what obesity medicine actually was. Now, they're actually calling us, slamming the table that they're going to go bankrupt next year, with coverage of the GLP-1 drugs. So the dynamic of the conversation has definitely shifted. And I think this reframing that is happening at both a national and a global level of the awareness of how the treatment of obesity can impact positively health. For some organizations, they view it from a negative connotation, from an expense line item perspective. And I think our objective, has been over the last few years and going forward is how to really reframe that as well into the fact that this is an investment into the health of your members, into the health of your employees, and that actually is a positive ROI investment. And that doesn't mean conflating what we see in the market as the conflation of an entire subspecialty of medicine with one medication or one class of medication. But if you adopt this principle of evaluating someone comprehensively for obesity and really optimizing everything you can from a behavior lifestyle perspective, optimizing that clinical model, and using a whole armamentarium of medications, not just the new GLP-1 drugs, it actually is a great investment. Maybe not for certain organizations that have a very sort of near-term, window where they have members that, come off their plan and on their plan every 3, 6, 9, 12 months. But for a lot of our clients, they know that the health of their employee population, the health of their member base over the next 12, 24, 36 months, or some even like with the state of Connecticut into retirement is going to be their liability. And they'd rather invest now for that benefit than suffer the consequences in many different ways down the road.
So are you saying that more the employers who have employee who tend to be sticky with the employer are the one who willing to invest?
Exactly.
And as you know that, 50 years ago, everybody stayed in the company for 20 years. And then now some people stay for 2 years. Even that is considered long enough.
Tenure too. Yeah.
And I don't know, maybe with the whole AI, nobody even have to work full time anymore. How's that? Do you see that is changing, or there's still a huge majority of the employee still work for a company for a long period of time?
I think it definitely depends. I think there's certain industries, there's certain sort of positions that are more transient. But I still think there is a very large cohort of, employers that really have a longer term outlook in mind. Some because it is fiscally responsible. I mean, they know that person is going to be on their pension or retirement plan. Others are doing it for more, qualitative reasons, for, employee retention, employee satisfaction. And I think, we just need to be very mindful, of those dynamics when we have those various conversations. But I think I would classify, that latter group as the majority of employers in the U.S. Mm-hmm. And also, even if you think about it, even, the single payer, marketplaces would be an applicable sort of comparable.
So tell me more about the work that you guys are doing with the state of Connecticut. And how is that a case study that maybe can help you translate to more employers to adopt your technology?
Yeah, so it's been a great partnership with the state. Comptroller Scanlon has been a great supporter from the beginning. So the state, we started conversations with them almost 2.5 years ago as they started to see their GLP-1 costs really accelerate. A lot of off-label prescribing, a lot of discontinuation, and just a lot of waste around the GLP-1 class of drugs on their pharmacy side. And so we worked with them to implement a program that we launched last July, so a little over a year ago, that really gives every state employee and now every state retiree access to evidence-based protocols, a behavior lifestyle program, and ongoing care and support by an entire team of medical doctors, nurse practitioners, registered dietitians. And over the last 12 months, and we actually shared our 12-month data with the state that we're actually working with a leading actuary firm and publishing shortly, we've seen great outcomes. So really, really high adherence, surpassing clinical trial level weight outcomes, corresponding biomarker improvements, whether it be, cholesterol, A1C, blood pressure, and really excited to share that data more broadly, over the coming months as we start to correlate that with their PBM data and also their claims data. And from there, what we're doing as part of our expansion, so we just signed a multi-year agreement with the state to expand that program, is coordinating with other provider groups around Connecticut. So enabling other providers in Connecticut to be included in the Center of Excellence model and really leveraging what we've been doing in Connecticut, but also more broadly in terms of delivering a more cost-effective weight program for every individual who meets the eligibility criteria.
Sometimes being a private sector, we don't think about the state as an employer, and actually state has a lot of employees. And how did that go about? Like, how do you pick the state of Connecticut? I know you mentioned that they got a soaring cost of the drugs and they want to help the employees, but also manage their costs, right?
Yeah, so the state, through their investment vehicle, Connecticut Innovations, is an investor. And so when they were evaluating different solutions, we worked with them to understand where we saw value in certain solutions and where there were opportunities to invest even more resources in finding and setting up an optimized pathway.
And do you think now that at least we see more on a headline now? I mean, one thing that there's no shortages of supply now, at least on the drugs. There's a lot more news saying that it's not working for everybody. And some have a lot of side effects. And I think compared to the news 7-8 months ago, I feel like, my God, this is the wonder drugs. I feel like now everybody kind of, hold on a minute.
I think there's a lot of noise. I think there's a lot of competing priorities of, competing interests. I think certain industries have a lot to lose from a medical approach to treating weight. I'm not a clinician. I guess I'm just married to one. I spend a lot of time with obesity specialists. I think there is a perspective from the clinical, experts that a lot of the side effects are actually due to poor clinical prescribing. Not doing enough work up front to really do a comprehensive initial evaluation, really understand all the contributors to weight gain, really do a comprehensive evaluation that optimizes what those medication protocols are. And some of these side effects are actually just due to extreme weight loss over a short period of time that you actually do see in certain bariatric surgery outcomes as well. Mm-hmm. So I think there's a lot of weight put on the class of GLP-1 drugs, both good and bad. And these are, very powerful medications. So there definitely are side effects. Mm-hmm. And I think that's why, you need a comprehensive ecosystem of support, expertise around that for ongoing support and adjustment that allows people to be on these medications. For most people, it's going to need to be long term, and that's how they're indicated. Obesity is a chronic disease that needs to be treated long term, similar to diabetes, hypertension, hyperlipidemia. And I think you're starting to see a lot of different approaches that are really not evidence-based and peer-reviewed. Some are, in our opinion, being derived to support commercial business models, devoid of clinical foundation. And I think, where we see opportunity is publishing the data that we are able to produce and showing and leading by example, and showing, where we see opportunity in creating a more cost-effective and efficient way to afford access to as many people who need this type of care.
Mm-hmm. Well, thank you for sharing that. Maybe it's a good time to segue to a little bit about your founder's journey. I'm sure people always ask the question, especially some investor, I'm sure, is like, being a husband and wife company, what is the story that you tell them that, hey, it works?
It's a good question. It's been a long journey. I will say. I think I joke. Catherine and I, work at the same company, but we don't work together. I think it helps that we really do focus on different sides of the organization. We have different, sides of the brain, as I joke. And I think that intention on, division of labor is a good one. I do think, and we've been told this countless times from investors, it is a serious risk factor. I think, investing, putting my investor hat on for a little bit, investing is a hard business. You need to identify a lot of the risks. You need to, proactively try to mitigate those risks. You need to structure around what those risks are. So, why in the world would you ever, proactively invite, more risks into, that investment? And so I think you can't invest by proxy for a lot of these things. But I think, we've been fortunate to have a dedicated group of investors from the beginning and have been growing that investor stable over the last few years. We have some exciting announcements to come on that front. And I think, at the end of the day, or I guess when we started out on this journey together, we recognized what those risk factors were and proactively addressed and mitigated those. And I think as we navigate forward, we're always thinking of what more we can be doing to do that. So we'll see how things progress, over the coming few years. But I think in this situation, we've been very fortunate to have that duality of expertise, because I do think it is a unique skill set and unique advantage given the complexity of what we're trying to tackle.
And actually, you end up spending a lot more time solving the problem because it's become 24/7, really.
It has, in addition to watching our 3 children, but it has been quite, I would say, as I joke, or as Catherine and I joke, when we launched the company in 2018, we had 1 child, and we were not anticipating twins in 2020, compounded by COVID, and a lot of accelerated growth for the company. So a confluence of events, but we are very fortunate to be where we are today, and we wouldn't have traded it for the world. And I think we're working on some things that are really going to change the paradigm of what we've been working on in a very good way that we're excited about.
That's great. I read it somewhere. I feel like when you're young, you don't really know how to increase your capacity with the same number of time. And as you get older and more mature, somehow you can pack more things, because you're work smarter, you're more effective, you know how to prioritize better, that you can pack more things. I think you're a perfect example.
Or at least you'd like to think so. Sometimes I'm not too sure. If I feel more productive or I actually am more productive.
Yeah. So a couple more questions before, because we are short on time too. You mentioned that you're investors in the real estate space. Is there something in there that you learn that you brought to where you are today? What are the key lessons learned there that you felt like, okay, this is something that I'm going to apply to the company?
Yeah, there are a lot of commonalities that gave me comfort as we went down this path with FlyteHealth. What I love doing as an investor are solving problems, and how buildings or organizations are run. If you break down those larger problems into smaller problems, there are a lot of similarities in terms of how you can take a rundown building, improve the systems, whether it be sort of operational or mechanical, lease it up, put some value into it to optimize the dividend yield of that one asset or portfolio of assets. There are a lot of commonalities to how we have thought about improving clinical operations and the workflow and the patient journey of those operations. And so, even as we look to partnerships or other areas of synergy for our business, we are exploring, bricks and mortar. We are exploring other related conditions. We're exploring a number of different areas that I think have parallels to larger real estate operating companies. And even, part of what we invested in a lot historically were hospitality companies. And so there are a lot of learnings there between healthcare and hospitality that both good and bad. I mean, a lot of different dynamics as well in terms of regulatory and other dynamics. But I do think that some of my past experiences have led to some of the initiatives that we've launched at FlyteHealth, and I think have been well received in the market. And I think as you think about where healthcare is going in terms of this consumerization of healthcare and this pervasiveness between virtual and in person, I think there are a lot of lessons in other industries that can be gleaned.
And I also oftentimes heard that, I think Vino Kusla said this, that many people who are investor, they were never an operator, and they always tell the company how to do things. Now you kind of do both. And if you have to tell your old self when you were an investor, what did you not know then that you thought that you know?
Anything about operations. It's a true characterization what you're referencing. I think it's a different side of the brain, and I think a good investor, depending on what type of investments he's making, I would say it's not as applicable to a public market investor. But as you start to think about venture and some private equity, value add, opportunistic investments, having a core foundational understanding of the operations, management science behind it, or at the least awareness of where you don't know, and invest in resources that have those capabilities. I think that is a skill set that a lot of private market investors, don't have, or at least could probably use some work on. And I think, vice versa. I think you see a lot of operators, trying to turn investors. And I think, it's funny, the level of optimism, it's sort of it's like an inverse, right? And so I get that. I get that actually quite a bit. I'm a very pessimistic operator, I guess, or an entrepreneur. I plan for the worst and hope for the best, or, however the metaphor is. But I think it's an interesting dynamic to navigate those two mindsets. And I see a lot of people have asked me that question a lot as you sort of navigate between those two personas. I think you need a little bit of both to be good at either. The question is what proportion?
Yeah. Striking balance is an impossible journey.
Impossible.
I think, but it's always keep moving. Hopefully it's not too extreme, right? It's just somehow we have to be confident, yet we have to be humble. It's all this polarizing characteristic that you need to have. Well, thank you for your time and thanks for sharing your insight. Looking forward to all the great work that you and your team are doing.
No, thanks very much for having me. And thanks again for all your support from the beginning. I mean, Rosamond has been such a great foundation for us to grow from and such a fantastic community to be a part of. We were really grateful for that opportunity.
That's great. Well, thank you. Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minotto, and thank you for listening.